Okay, ठीक आहे. ठीक आहे मॅम. At least I can share and by the time my turn comes it should work.
कॅमेरावर काही नाहीये ना?
नाही.
कॅमेरावर काही
आता मगाशी दिसलं होतं. I don't know what's happening with that.
काही स्टिकर वगैरे का?
नाही नाही नाही.
कारण कधी कधी काहीतरी
मगाशी दिसलं होतं ना.
असं कॅमेरावर कव्हरिंग काहीतरी वाटतंय.
हम्म. हॅलो राजेश ओटी मधून जॉईन करतोय ऍज युजल. खूप काम करतात हे सगळे लोक बाबा.
अहो आमचं शेड्यूल नसतं आमचं ते. सकाळी रिकाम असतो, संध्याकाळी बिझी होतं, असं असतं ते.
ठीक आहे ना. That's okay. I told them.
कर्णिक वेलकम कर्णिक मॅडम.
कर्णिक मॅडम जॉईन झालेत का?
Yes, I have joined. Hello.
हॅलो, गुड इव्हनिंग मॅम.
गुड इव्हनिंग मॅम.
Good evening. Hello.
मॅडम नमस्कार.
Namaskar. Hello.
नमस्कार. गुड इव्हनिंग मॅडम. हा गुड
Good evening, all.
गुड इव्हनिंग. तुमचा विषय हा.
गुड इव्हनिंग कर्णिक मॅडम.
Hello.
न्यूरो तुमचा विषय आहे म्हटलं आता.
The topics are good.
टॉपिक सर कालचा प्रायव्हेट प्रॅक्टिशनर फोरम पण फार सुंदर झाला. त्याचं पंकज गुप्ताचं. मनीषा मॅडम म्हणतात ते बरोबर आहे का? आय एम जस्ट ट्रॅव्हलिंग फ्रॉम कोल्हापूर. कराडला जोरात पाऊस पडला पुण्यातून. म्हणजे त्या भागात पाऊस खूप जोरदार झाला.
हेमांगी मॅडम गुड इव्हनिंग.
काटेकर मॅडम गुड इव्हनिंग.
Good evening.
गुड इव्हनिंग.
Hello, ma'am. Hello, sir.
हॅलो.
Good evening.
गुड इव्हनिंग शीतल मॅडम.
Good evening.
हॅलो
Hi,
शीतल.
Shilpa. Hello.
हा रश्मी मॅडम दिसल्या.
अच्छा, येस झालं बघ. काय होतं ते समथिंग लॅपटॉपच काही होतं का? आता म्युटेड आहे. युअर म्युटेड.
Must be because I also don't know what's happened. Actually, I have tried first, so it was there working properly. Now only the issue came.
राजेश विल स्टार्ट शार्प ॲट 6:35.
येस येस. Good evening, all. Welcome, Katikar madam, Karnik madam, today's speaker, Dr. Shilpa Tivaskar ma'am, and Rashmi Chavan ma'am. This is in accordance with our webinar series, Safe Anesthesia Saves Lives. And this month we are dealing with the neurosurgery as well as the patient related with the CKD. Today's chairpersons are Dr. Manisha Katikar ma'am, the famous anesthesiologist and our past president of Maharashtra state. She has played every role in the state of Maharashtra, and now she is a GC member of National ISA. Welcome, ma'am. And Dr. Himangi Karnik, ma'am, both are the chairperson and today's speakers, Dr. Shilpa Tiwari ma'am and Rashmi Chavan ma'am. Shilpa Tiwari madam will be talking on the optimizing brain while anesthetizing its safe anesthesia practice, and Rashmi Chavan ma'am will talk with the CKD patient for fracture femur, principles of management and the private practice. I welcome you all, and I will request Dr. Anita madam to brief about our webinar.
Thank you, Rajesh. Good evening, everybody. And today we are taking one very important session on neuro and kidney patients. Like in private practice, we are having patients who have head injuries, and then we are not sure. Those patients keep coming to us for any peripheral surgeries or other surgeries. So today we want to know what are the guidelines, how much blood pressure we should keep. So actually there are changing concepts in the acceptable hypotension, in the auto regulation. There are concepts have recently changed. So we would like to know from our today's speakers, sir, and our respected chairpersons, that how exactly we must, how much blood pressure we should keep. If as a CKD patient, are there any principles in anesthesia that we should keep this much blood pressure, or which anesthesia to give? So very important topic for private practitioners. And I want to now introduce Dr. Manisha Katikar madam. Manisha Katikar madam doesn't actually need any introduction. She is my close friend and our beloved past president of Maharashtra state. And she is working as a neuroanesthetist. She has her own private hospital, Balwant Institute of Neurosurgery and Intensive Trauma Care. She also works as intensivist in her hospital, and she is a GC member of ISA National at present. She has held so many posts at SAMS level. She was a past president, vice president, secretary, as well as NISA News editor of SAMS. So I welcome you, Dr. Manisha, to this SAMS webinar. I'm very happy and proud to welcome Dr. Manisha.
Thank you so much, Dr. Anita. It is always pleasure to join SAM's activities.
Yes, our next introduction. Saurabh,
Yes.
please introduce.
Good evening, ma'am. Good evening, Manisha, ma'am.
Good evening.
I'm going to introduce Dr. Himangi Karnik, ma'am. She is professor in anesthesiology in LTM Medical College, Mumbai, a well-known figure in neuroanesthesia and neurocritical care. She is a recipient of Hargovind Foundation Medical Fellowship in the year 2000. She is visiting professor, Stanford University Hospital. She is on editorial committee. She is an editorial committee member of various journals. She has edited the book titled Practical Approach to Anesthesia and Emergency Surgery. She has more than 40 publications and book chapters. She is faculty at various conferences and delivered multiple talks, including orations. In fact, in 2014, when I was secretary at ISA Nagpur City branch, I had invited her for prestigious E.G. Tambe Memorial Oration of ISA NCB. Her areas of interest are trauma anesthesia, monitoring, ethics in research, apart from neuroanesthesia and neurocritical care. Welcome, ma'am.
Thank you, Dr. Saurabh. That was indeed a great honor for me on that year. Yeah. Thank you.
Thank you, ma'am. Today's first speaker, Dr. Shilpa Tiwari, I would like to introduce her. She is presently working as a senior consultant in the Bhakti Vedanta Hospital and Research Center, and presently she is a GC member of SAN, that is Society of Anesthesiologists, Maharashtra State, and a founder member of ISA Borivali, very active personality in ISA Borivali. She is affiliated, as already I have told, with the Bhaktivedanta Hospital, and her areas of interest are special interest in the regional anesthesia, critical care, and difficult airway. She is a trained tutor for PLS, BCLS, and ACLS instructor. Special interest in USG guided nerve blocks and pediatric anesthesia and high risk cardiac cases. She has received so many awards from the state and national. Few of them are public awareness awards, thanks to 2022-23, President Appreciation Awards in 22-23, ISA National Diligence Award. She has also received ISA National Proficiency Award in 2023-24. She was a organizing secretary of biennial savings at Borivali, and she has received Best City Branch Award during her secretary ISA Borivali tenure. She has many publications. Few of them are publication in National Peer Reviewed Journal on chiral molecule and PAC, publication in IJN on biomarkers in the critical care, and she has written a chapter in Medicine Update 2016 on hypertension. Publication in Index Journal regarding cases of fracture tumor and anesthesia. So I would like to request introduction of the next speaker.
Thank you, Dr. Rajesh, sir. That was too elaborate.
Good evening, all. On behalf of SAM, I take a pleasure in inviting renowned and experienced speaker and a teacher, Dr. Rashmi Chavan, Madam. Madam, welcome to SAM's webinar. Madam is an experienced teacher. She's been into teaching since last 20 years at DY Patil Hospital. She has several fellowships and she's done various courses in many areas. She has fellowship in interventional pain medicine, which she acquired in 2015. And following that, she's done several courses like course in echocardiography, then biomedical research, and reviewer course and e-content development course. She has a very elaborate CV, and Madam is a course instructor and she's a teacher in DY Patil Hospital since last 20 years. And she was the secretary of ISA Kolhapur, and at present she's holding the post of president-elect of ISA Kolhapur City branch. And Madam, I welcome you. She has several publications and lectures.
Thank you, madam, for so much.
So I request Dr. Shilpa to please start sharing her screen and begin with her lecture.
Yes, so at the outset, thank you, SANS. Thank you, Anita Madam, Rajesh sir, for giving me this opportunity, and it gives immense pleasure to present neuroanesthesia in front of two stalwarts of neuroanesthesia, Anisha Katekar Madam and Himangi Karnik Madam. I hope I live up to their expectations. Yeah, so optimizing brain while anesthetizing it. Safe neuroanesthesia as the topic of sciences. So my today's agenda will be normal cerebral physiology, autoregulation, and blood-brain barrier, which anesthesiologist should know in private practice also, preoperative optimization, intraoperative strategies, postoperative care, and I would like to share few cases. Now, the normal physiology. Cerebral perfusion pressure. Normally, if I'm anesthetizing a neuro patient, in my mind, it will be, okay, I have to maintain a mean arterial pressure so that cerebral perfusion pressure will be maintained. But remember, as we maintain the MAP to 60, the CPP, the cerebral perfusion pressure, will be 60 minus the intracranial pressure. So whenever there is any trauma case, we have slight elevation of the intracranial pressure. If it is above 15, remember your MAP, as Anita madam was saying in the beginning, the MAP, the newer concept, the MAP should be more so that the CPP should be at least 50 millimeters of mercury. So this is from the latest BJA article in June 2024. So it says that now the cerebral blood flow has an auto-regulation. It is like a stubborn child. It will not listen to whatever cerebral perfusion pressure is. It will say that I will do my work alone. So at cerebral perfusion pressures between 40 to 90, the cerebral blood flow auto-regulates itself. Means, and at MAP of the new guideline says, initially it was 60 to 160. Now the newer guidelines say that mean arterial pressures of 50 to 150, between that, the cerebral blood flow will auto-regulate itself. What does auto-regulation mean? If you see that it will keep on changing the blood vessel size. If the BP is less, the cerebral blood vessels will dilate. If the blood pressure is more, 150, they will constrict. And this auto-regulation will be there. If you see on the right extreme, if BP crosses mean arterial pressure above 150, then there could be disruption of blood-brain barrier. There could be vasogenic edema. And on the left side, if you see, if the mean arterial pressure is less than 50, then cerebral hypoxia ensues. Now, according to the guidelines, if the mean arterial is above 150, you might take still some time. You have still some time till it becomes 160 or 170 to control it so that you have good cerebral perfusion pressure. But on the lower side, as soon as the mean arterial pressure drops below 50, brain starts becoming hypoxic. So brain hypoxia ensues immediately. It doesn't give time. Now, in short, factors affecting cerebral autoregulation. Why we should know them? So that we can alter them if required during the case. Now, myogenic factor. Myogenic factor means just stretch receptors are present in the smooth muscle. And remember, the autoregulation means what? Whenever there is increase in blood pressure, these smooth muscle cells will contract and will cause decrease in blood supply to the brain, and hence the pressure will decrease. Similarly, whenever there is decrease in blood pressure, the smooth muscle cells will dilate and increase blood supply to the brain. Basically, they have to maintain the blood supply to the brain. This diagram appears complex, but it is just the blood supply of the brain. This is the anterior blood supply. On the right side is the posterior blood supply. The complexity will go if you see on the right side. There are some adrenoreceptors, there are some calcium receptors. So basically what? In the anterior circulation of the brain, there are more adrenoreceptors, and in the posterior circulation, the sympathetic receptors are less. Now what is the significance? If we have heard of Press syndrome. So what happens whenever the pressures are above the cerebral autoregulation, immediately the posterior part, which cannot autoregulate itself above the limits, it starts becoming either hypoxic, or if the BP is increased, we see that when there is one episode of at least hypertension, then we have Press syndrome. Then we have vasogenic edema. That means the fluid comes out of the blood vessel. So hence the posterior part of the brain is more vulnerable. Again, there is something called neurogenic control, where the neurons, astrocytes, microglia, they will produce some neurotransmitters, which when sympathetic stimulation is there, they will cause constriction. Parasympathetic, it will dilate. The main studies which are going on nitric oxide, and of course, the vasoconstriction by serotonin and neuropeptide gamma. Now, this is what we can alter during our case, the metabolic mechanism of cerebral blood flow autoregulation. There are three factors: carbon dioxide, hydrogen ion, and oxygen concentration. Now, carbon dioxide, if you see the last line, for every millimeter increase in PCO2, the blood flow decreases by 4%. So that is very significant, right? So what if there is, what happens? Suppose there is decrease in blood pressure and there is CO2 accumulation in the brain. Then what will happen? Accumulation of CO2 will cause vasodilatation. It will increase the blood flow and hence take away the increased carbon dioxide. So carbon dioxide increase is a good stimulator for increasing the blood flow. If you see 70% increase in the arterial PCO2 doubles the cerebral blood flow. But remember, whenever there is traumatic brain injury, head injury, there is the cerebral blood flow as it is decreased by 50%. So for increased intracranial pressure, if you try to hyperventilation, what it will do? It will decrease carbon dioxide in the brain. So if carbon dioxide is decreased, what the blood vessels will do? They will constrict because now they don't have to empty the carbon dioxide. So once the blood vessels constrict, we feel that intracranial pressure might decrease. But remember that cerebral blood flow is already in a compromised state. So in order to decrease intracranial pressure, do not hyperventilate so much. You will already compromise the compromised cerebral blood flow. Secondly, it is surprising. Normally, we say that it's okay to have a low PaO2. We can keep PaO2 the 50-50%, or if there is any hypotension or anything, then only we increase the PaO2. But the cerebral tissue requires maximum oxygen. If it takes cardiac output, if it takes 15%, then oxygen, it requires the total oxygen in the body, at least 20% of the total oxygen and 3.5 ml of oxygen per 100 grams. Hence, whenever it does not tolerate hypoxia at all, remember, whenever there is hypotension, hypoxia, secondary brain injury starts. So do not accept any saturation below 95% in a cerebral case. Of course, the last very minimal control is the endothelial control of autoregulation, because more of the blood in the brain, 70% is in the venous circulation in the small capillaries. And hence, accordingly to vasoconstrict or to vasodilate, they keep on releasing neurotransmitters, the nitric oxide, the H ion, the lactates. Whenever there is increase in lactate, there will be vasodilatation. So just as a revision, the normal cerebral blood flow is 50 to 65 ml per 100 gram. Weight of the brain, if you consider, then the entire blood flow is around 900 ml, 15% of resting cardiac output. In pathological conditions, whenever there is decrease, suppose there is a stroke and there is decreased blood supply, then at that point it is 10 to 15 ml only, but the area around the stroke or the hemorrhage, which we have to save, the penumbra area, there the blood supply, which is reversible neuronal damage, the blood supply is 15 to 20 ml per 100 gram, and we concentrate on that area. This is the cerebral circulation, we all know. This is the disruption of the blood-brain barrier. So what happens? Whenever there is disruption of blood-brain barrier because of stroke, chronic hypertension, traumatic brain injury, multiple sclerosis, dementia, or any neuroinflammation, then these toxins which are there, they are released into the blood. And what happens? The removal of the waste products and toxins from the brain is decreased. And these toxins, which are neurotoxic, they will cause cellular damage. Hence, in traumatic brain injury, these mechanisms which cause cellular damage is called as secondary damage, which occurs not because of the injury, but because of the disruption of the blood-brain barrier. Now, what we feel when we are inducing a neuro case? Okay, I have to maintain mean arterial pressure. Acha, mera 70 hai, I am happy. But remember, it is not a very static. It is a dynamic circulation. It is a dynamic process. So if you have large variations in blood pressure, the cerebral blood flow, though it is auto-regulated, it takes time to auto-regulate, and hence there will be fluctuations in cerebral blood flow. So remember, during a neurological case, you have to minimize fluctuations in blood pressure. So during surgery and critical illness, postural changes, some form of exercise Whenever there are high fluctuations, the cerebral blood flow takes time normally also to auto-regulate, and hence it will follow blood pressure. One more common thing, which even I used to believe during my PG days or maybe later till some time, that the patients with blood pressure, they require a higher blood pressure to because they are auto-regulated at a higher level, the cerebral blood flow. Normally it is 50 to 150, so mean arterial pressure. So I used to think, no, the hypertensive, I should keep a higher blood flow. So it is not so unless you have traumatic brain injury. And there we will see that the autoregulation itself changes. And also in elderly, the latest guidelines, what they say is, in elderly also, you did not keep the blood pressure at a higher level. Also, this autoregulation is not an all and none phenomena. Suppose for carbon dioxide, the reactivity is not there, but it does not mean that it will not react to sympathetic stimulation. So, and this cerebral autoregulation is different in different areas. Now, coming to the management of neuropace, we have principles of management. Every one of us do that regularly. We look at preoperative hemoglobin. We see if the blood pressure is controlled. We see the coagulopathy, seizure prophylaxis, reduction of increased intracranial pressure. The surgeon usually takes 5 to 6 hours to optimize the patient to decrease the intracranial pressure. Then all obtended patients, remember, we need to have a baseline ABG to see that our EtCO2 is correlating with the PaCO2. Serum electrolytes are important. We'll see that. Need of central line and arterial line. If the patient is moderate traumatic brain injury, where the Laxocoma scale is less than 13, between 9 to 13, then you need to have a central line. If you need to give any drugs, an arterial line for continuous monitoring of blood pressure. Your threshold to put this line should be low. You should be immediately putting these lines. How to say, we'll see how to select patients for awake craniotomy, choice of induction agent, intraoperative fluids, brain relaxation, intraoperative hypotension, whether to be given or not, hypothermia, and avoid hypoxemia. Now, why blood transfusion? Remember that brain is, like a catabolic substrate. What it will do? Anaerobic. So it will take lot of oxygen, lot of substrate. The oxygen consumption is around 40 to 70 ml per minute. And hence, whenever there is low hemoglobin, the first thing gets compromised is the oxygen supply to the brain. And hence, we need to transfuse. What are the transfusion levels? Okay, this is again, it gets 15% of cardiac output, 20% of available oxygen. So what happens in chronic anemia or acute anemia where the autoregulation is preserved? If you see, the blood vessels increase. So what happens? They try to compensate. There is anemia, so oxygen is less. So the blood vessels will increase. They not only they will vasodilate, but they will increase in number, and hence they will compensate for the chronic anemia or acute anemia where autoregulation is maintained. But in acute anemia, when the autoregulation is disrupted, then in that case, anemia will immediately cause decreased oxygen and it can cause hypoxic cerebral injury. Ischemia it can cause. Hence, for traumatic brain injury, the hemoglobin concentration more than 9 gram% was associated with good neurological outcome followed up to 6 months. And with HB less than 9 gram%, the brain oxygen tension was less than 20 millimeters of mercury, and which was a poor risk factor for neurological outcome. But the latest guidelines for if you're doing a tumor operation, then they say you have to have a restrictive hemoglobin threshold of 8 grams per DL to be safe and to minimize the post-operative complications. On the right side, as I have said, anemia, it increases blood flow. When there is anemia, increase blood flow to meet the metabolic demand. So remember, the blood volume also increases and intracranial pressure increases. Anemia, of course, decreases the oxygen supply. Now, one more interesting fact. We feel, as I said, the elderly as well as the hypertensives, they don't have a higher cerebral autoregulation. Similarly, they have done a study and they have found, this is the latest study, that if you keep the blood pressure controlled, then what happens? If the blood pressure is controlled, then what will happen? The vessels will vasodilate. See, if there is high blood pressure, they vasoconstrict and try to decrease the supply to the brain. But if the blood pressure is controlled, the cerebral vessels will vasodilate. And what happens? Not only the blood supply to the gray matter is increased, but they have found that blood supply to the white matter is also increased. So remember that to maintain preoperative blood pressure, also intraoperatively, it is not necessary to maintain a higher blood pressure to improve circulation. In fact, as we saw all the mechanisms, the neuronal mechanisms, the myogenic mechanisms, if you maintain high blood pressure, then the cerebral blood flow will be compensatory decrease and it will affect cerebral circulation, especially the penumbra area. Now, again, we have receptors, baroreflex to maintain the BP. But remember, there are trials, in same what I said, infinity and sprint trials, where hypertension, okay, now they have said that all these neuronal diseases such as Alzheimer and Parkinsonism, they can be increased chances if the hypertension in the patient is not treated, because hypertension causes chronic mild cerebral hypoperfusion. Then preoperatively coagulation, whether we should correct or not. Initially, our neurosurgeons used to say, okay, if the platelet is less than traumatic brain injury, platelet is less than 1, transfuse. And we were like, our guidelines that time previously, around 15, 20 years back, it was guidelines was not 75, but 50 or 75. They were like 80, 90, we'll see whether to transfuse or not. So remember that, especially in traumatic brain injury, and if it is an aneurysmal subarachnoid hemorrhage, then the blood loss occurs more and more as the time goes. And hence, you need to transfuse these patients. In traumatic brain injury, you need to maintain the platelet count at least up to 1 lakh. And hence, we always do platelet transfusion if there is a polytrauma, traumatic brain injury, or a clipping of the subarachnoid hemorrhage. Platelets are ordered and we maintain count at least till 1 lakh. Yes, again, the same study. Thrombocytopenia is associated with increased mortality in traumatic brain injury. Again, now whether to use hypertonic saline or to use mannitol. Of course, whatever our neurosurgeon says, we do that. But as we have seen since last 5-6 years, the studies have come that hypertonic saline, it will decrease the cerebral edema, decrease the intracranial pressure, and at the same time, what happens? The intravascular volume increases and hence the cerebral perfusion pressure increases. Remember, the cerebral perfusion pressure is different and cerebral blood volume is different. So cerebral blood volume will increase, the perfusion pressure will increase, but at the same time, it will decrease the intracranial pressure. What about mannitol? Now, why still, though the hypertonic saline has some side effects, but it is more efficient. But still, why do we use mannitol in our daily practice? Because the hypertonic saline, it can cause if given faster. We cannot start in ICU and not monitor it. Even though there is staff, it may go faster than normal. And then it can cause pontine myelinosis. It can cause hyperoncotic hemolysis. And it requires a central line. A peripheral line, it can cause phlebitis, even if it is a big vein. And hence hypertonic saline is in routine practice not preferred. But it is more advantageous. When we give mannitol, when the surgeon tells us to give mannitol, remember we have to see the creatinine level of the patient. We have to initially give a lesser dose, 0.25 grams per kg, and acquire if increased, if required. Then of same study, practice guidelines. Yeah. So, okay. So whether to give now, we see, of course, nowadays it has become routine, everyone gets mannitol, everyone gets dexamethasone, everyone gets Levipril or levetiracetam. So what is that? It is nothing but an anticonvulsant which should be given. So ideally they say there is weak evidence whether anticonvulsant should be given or not, and whether if at all you have to give, and there is a comparison between phenytoin and levipril or levetiracetam, then you have to give levetiracetam for 7 days as a prophylaxis to prevent convulsions. Now comes our induction agent, which to prefer. Now, propofol, thiopentone, midazolam, etomidate all decrease the cerebral metabolic rate of oxygen consumption. They decrease the cerebral blood flow to a certain limit, not to cause hypotension or not to decrease cerebral perfusion pressure, but they decrease the intracranial pressure. Ketamine is not given. It was not advocated till last year. But again, of course, there is a research. They say that ketamine, if there is a polytrauma patient, if there is a sepsis where you cannot give ethomidate or hemodynamically unstable patient, then ketamine can be used in lower doses. Now, okay, now though propofol maintains auto-regulation, cerebral auto-regulation, we have to remember that in a study they have, this is just one study, but there are many studies that after propofol induction, there is some decrease in the cerebral perfusion pressure, and the first choice of drug to be used is noradrenaline, where you have to give small dose of noradrenaline after induction to restore the cerebral blood flow. Yeah, regarding electrolytes, we all know that whenever there is brain injury, there could be a syndrome of inappropriate secretion of antidiuretic hormone. There could be cerebral salt wasting syndrome. There is hyponatremia and decrease osmolarity or decrease oncotic pressure. And hence, we need to do serum electrolytes and correct serum sodium before the surgery. We can correct by giving normal saline, unless it is very less than 125 and we need to give hypertonic saline. Again, same, they say a combination of propofol and remifentanil provides best preservation for autoregulation. Inhalation agents, they say better to avoid, they do not give that much advantage in autoregulation, but sevoflurane to some extent, to up to 1 mAh can preserve autoregulation at all doses, it is written here, but usually up to 1 to 1.5 mAh, it preserves autoregulation. All doses in this study. Then, suppose intraoperatively, you find that there are fluctuations in blood pressure. With the blood pressure and the CPP, the autoregulation is disturbed in a traumatic brain injury, suppose patient. Then are there any chances? As I said, the autoregulation is not all and none phenomenon. It is different in different areas. So are there chances where we can regain that autoregulation? Yes. You can start vasoactive agents to maintain the mean arterial pressure. Then you can do hyperventilation to decrease the intracranial pressure. You can increase the oxygen levels and use mannitol or hypoteric saline. At times, Lasix or furosemide also can be given. So all these measures intraoperatively to maintain cerebral autoregulation can be done. Preoperative strategies. Preoperatively, we have to confirm. Now, pupillary reactivity, we do not see. But if you see, then we can find that there could be signs of tentorial herniation. The pupils are not reacting, they're unequal. Then you have to see that there could be an increase in intracranial pressure. So before inducing or before opening of the dura, this increase in intracranial pressure need to be managed. If there is a trauma patient, of course, the routine cervical spine mobilization, nasal intubation should be avoided. Rapid sequence induction should be done. Ketamine should be, the large dose ketamine should be avoided. Propofol should be given slowly. Lignocaine is said to be neuroprotective and can be used for laryngoscopic response. Suppose there is increase in blood pressure, do not use nitroglycerin NPG. Why? It will vasodilate and it will increase blood supply to the brain and further increase intracranial pressure, and hence labetalol, which is Alpha as well as beta blocker is the first line of drug for increased blood pressure. And always, if you are putting an endotracheal tube, see that you have sedated and paralyzed the patient. Mild hypocapnia is okay. Now, avoid glucose-containing solutions. Why? It will cause lactic acidosis. And again, what will happen? Increase blood supply and increase intracranial pressure. If there is hyperglycemia, maybe because of steroids or because of injury, lot of cortisol and catecholamines are released. So if there is hyperglycemia, give insulin. Same. Okay, central venous pressure monitoring, as I told you, to monitor the intravascular volume for resuscitation, inotropic support, arterial line for blood gases, and if you need to have a big-to-big measurement, avoid secondary injury. Avoid any hypotension, any hypoxia, because then you will have a secondary brain injury. Okay, regarding temperature, initially it was thought that hypothermia would be helpful, but now they say hypothermia can be used as a last resort to decrease the intracranial pressure, and hyperthermia can exacerbate the brain injury and cause worst outcome. So it is better to maintain normothermia. Initially, it was thought a 30-degree high up to decrease the intracranial pressure, but we as know for every 10-degree increase in the head high, what will happen? The cerebral perfusion pressure will decrease, and hence only 10 to 15-degree head high is advocated. Nowadays, I see increased incidence of awake craniotomy. It's become a fashion. Do all case in awake craniotomy. But remember that whenever there is an head injury, and if the Glasgow Coma scale is less than 8, patient is unlikely to protect his airway, and you should not do these patients under awake craniotomy. It should be done only if you have to do the motor area mapping and of course the sensory cortex if there is any lesion there. Otherwise, awake craniotomy should not be casually used for all the patients. Brain relaxation. Dexmedetomidine is the best drug which is found for brain relaxation. What it does, it is a neuroprotection. It inhibits the ischemia-induced norepinephrine release. At the sites where there is ischemia, norepinephrine is released, it inhibits that. It delays the neuronal death after focal ischemia, and it decreases the total ischemic volume by 40%. There's a beautiful article in IJA in 2024, which gives insights about new update in neuroanesthesia and neurocritical care. What it says, ketamine has been proposed as a neuroprotectant for analgesic, anti-inflammatory, sympathomimetic, and anti-seizure, and so it is an anti-seizure. So how the evidence keeps on changing. Till few years back, we used to consider ketamine not to be given in seizure patients, not to be given in neuro patients, but they say it is a neuroprotectant along with dexmedetomidine, and it should be used. So role of ketamine is in preventing or delaying the cerebral ischemia through separation of cortical spreading depolarization, and that is also under evaluation. This article also tells about opioid-free anesthesia to be used in neuroanesthesia, total intravenous anesthesia techniques to facilitate intraoperative neuromonitoring, which is nowadays done for most of the patients where they are operating on any tumor, and awake neurosurgical and spine surgeries. Now, Anita madam has told me to talk something about traumatic brain injury. So quickly, another 5 minutes. So traumatic brain injury, we have a varied presentation and there is a cascade of events. The primary event is the injury, which has lacerations, contusions, hemorrhages. Yes, but what is main important is the secondary injury. Remember, all systems are affected. The natural response to injury is affected. There is excessive damage. There is oxidative stress. Reactive oxygen species are released by cell damage. The neurotransmitter glutamate is released, which is harmful to the neurons. Then there is influx of calcium, which causes cell damage. So we see that lot of changes happen to the brain after the primary injury. And of course, we all know this Glasgow-Coma scale. And now this stands now also true if you have less than 9 score, then it is severe. These patients may have increased intracranial pressure. Now we all say cerebral regulation autoreg between 50 to 150, but in traumatic brain injury, the autoregulation itself becomes between 90 to 110. And hence you accordingly have to increase your mean arterial pressure above 90 in traumatic brain injury. Of course, the surgeon will ask for a lower BP when he's trying to open the skull. We have American College of Surgeons guidelines. We all know these guidelines about maintaining sodium levels, INR level, temperature level, platelet level, systolic blood pressure, oxygen, and CO2 levels. Now, traumatic brain injury with bone injury is a complex phenomena. What happens? The immune cells located at the fracture site, they proliferate and they release interleukin, tumor necrosis factor, and this evokes a secondary inflammatory response. And there is also disruption of the blood-brain barrier. So the traumatic brain injury worsens. But there are some recent articles which say that healing of the bone is better if the patient has traumatic brain injury because of the increase in cell proliferation. There are some guidelines of Society of Neuroscience in anesthesiology and critical care, same guidelines as we saw for temperature, oxygen, choice of anesthesia. They have also given guidelines for intraoperative aneurysm rupture, where they have said for transient decreased blood flow, you can use adenosine for a short brief time, of course, keeping pacemaker and this ready, drug ready. Just a small point, even if there is a mild traumatic brain injury, remember, is an activating factor to cause neurodegenerative diseases. Yes, so as Anita madam told me, of course, keep at least 2 to 3 cases. So here I am, a 34-year-old, I had a 34-year-old young patient around 3-4 years back with GCS 15 by 15, depressed skull fracture. Neuro said nothing to do for the skull and was posted for right tibia and left femur fracture. Now the question was whether to take immediately within 24 hours or whether to wait for the secondary injury, and can we give regional in this case. So after adequate resuscitation, ideally after any polytrauma, where though the GCS is 15 by 15 and nothing to do with the skull fracture, still we have to wait for 24 hours to see the extent of secondary injury. Regional central neuraxial blockade is not contraindicated in mild cases, but you have to see if the patient had altered mental status or focal neurological signs or signs of increased intracranial pressure on CT or MRI or a coagulopathy, then you should not give regional. But otherwise, regional is not contraindicated. We had given regional anesthesia since the neuro opinion was there on paper. We had given spinal and epidural anesthesia to this patient. But unfortunately, this patient, after 2 days, the depressed fracture, it became pneumoencephalus. And there was a midline shift and he had to be again taken to decompress that pneumoencephalus. Of course, here not to say, just to mention that epidural since last 15 years at least, I am giving with saline push. So there was nothing to do with our spinal epidural. It was just a depressed fracture, which again went into the skull and you had pneumoencephalus. Potential risk, yes. Oh, this is repeated. No, sorry. In that same case, suppose the GCS had decreased. GCS had become 13 by 15 and no spontaneous eye opening or the patient was drowsy. Then in this case, do we still proceed for tibia and femur? If the GCS is 13 by 15, no. Fixation of long bone or even maxillofacial fractures should be delayed and first the head injuries should be stabilized. Now here is a dilemma. If there is a maxillofacial injury, Then how do we anesthetize the patient? So maybe the maxillofacial fracture though the guidelines say you should treat it later on, but it can be fixed with local because sometimes doing nasal intubation also could be contraindicated. And after fixing that, you can operate the patient. Again, these cases which I had put on WhatsApp group. So 50-year-old patient with no comorbidities posted for decompression craniotomy. Though the guidelines say that for subdural hematoma, you may have 9 HB, but we had kept blood ready. And of course, we had to give in this patient after blood loss of around 200 ml 250, we had infused with 1 Paxil. In case for extradural hematoma, fracture humerus, 60-year-old, whether to operate first or to do humerus first, of course, to remove the extradural hematoma and then to operate the fracture humerus. And the last patient with BP of 160 systolic, what BP should we maintain intraoperatively? If it is a subdural hematoma, it is a traumatic brain injury, we need to maintain BP, at least mean BP above 90 systolic. Thank you. Thank you for patient hearing.
Excellent presentation, Shilpa.
Thank you.
And I now request Dr. Manisha Katikar madam for her comments.
Yeah, it was really an excellent presentation, Shilpa. Such a
Thank you,
vast
madam.
topic, very vast topic covered in half an hour or 45 minutes.
45 minutes.
Yeah, you included everything, including something about traumatic brain injury, something about awake craniotomy, physiology, cerebral autoregulation. So it was, I can say, it was really a comprehensive talk. I would like to add few things to what you have said. See, basically, whenever you give neuroanesthesia, the onus totally depends on the anesthesiologist, whether to go ahead with what drugs you are giving. You have to maintain hemodynamics, as you said correctly. You have to take care of ICP, that is, and both of this will help to take care of cerebral perfusion pressure. So, onus totally depends on you when you use the drugs intraoperatively. Whatever you are using, use the drugs which are neuroprotective. Hemodynamic stability is needed, basically needed to maintain cerebral autoregulation. So whatever may be the physiology of head injury, whether you understand anything or not, for any practicing anesthesiologist who may not be well versed with cerebral physiology, the basic thing he has to understand that he has to maintain hemodynamic stability in any patient who has sustained head injury. And this is why this is to maintain the cerebral autoregulation. And another thing is that few things are not in our hands, like the site of injury, the extent of injury. But then other things under anesthesia are our hands. And the most important thing you already mentioned is the PCO2 and the mean arterial pressure and oxygen saturation. So few things are in our hands that we have to take care. So there are, whatever may be the case, whether it is a traumatic brain injury or whether it is an elective brain surgery, we have to give importance and we have to maintain 4 N's. Maintain normotension, normoxia or maybe little hyperoxia, normocardia, normothermia, and maintain the blood sugar within normal limits, that is euglycemia. So 4N and 1 is required for any neurosurgical case, whether it is elective or emergency. So at the same time, now you have to avoid 5H, hypoxia, hypothermia or hyperthermia, then hypotension, hypercarbia, or even hypocarbia, which can lead to cerebral vasospasm, and even avoid hypoglycemia or hyperglycemia. So avoid 5H and maintain 4N and 1E. That should be the basic principles of neuroanesthesia. Yeah, you mentioned about the mean arterial pressure, that it should be maintained between 50 to 150 to maintain the cerebral perfusion pressure. So what will happen if the mean arterial pressure falls to a very low level? It will cause cerebral ischemia. We have to maintain and balance mean arterial pressure in such a way that if it is too low, it will cause cerebral ischemia. If it is too high, it will cause cerebral edema. So both these factors has to be taken into consideration when we are dealing with mean arterial pressure. Another point you mentioned is that if there is an increase in PaCO2, there is a 1 mm increase in PaCO2, there is 4% increase in cerebral blood flow. This is a very important point which should be stressed because as I already said, PCO2, maintenance of PTCO2, maintenance of ETCO2 is in our hand. And if we allow ETCO to rise, then definitely the cerebral blood flow will increase. Intraoperatively, it may create problem. Increase in CBF can lead to increase in ICP. Surgeons may have problem while operating. And this is very important that we have to remember. Baseline ABT, what you said is really important because many a times in old patients, in COPD patients, the room air PCO2 levels may be high and we should know about that. So this is very important message you gave. Another thing I would like to say about central line you said, yes, but then you have to avoid internal jugular vein cannulation because most of the neurosurgical interventions are done by turning the neck towards one side if the patient is in supine. So basically, if you want it, if the surgical case is going on and you want to put a central line, better to put a subclavian vein. That should be that's what I practice because then if there is a compression of IJV, then it will definitely create problems. Yes, another point which I do not agree, Himangi madam will also, whether she would like to say on it or not, is having a hemoglobin level of, yes, I say they are the guidelines, but having a hemoglobin level of 8 gram, that is restrictive blood transfusion protocols for elective neurosurgery. I would definitely not like to have because our Indian population is already anemic and a craniotomy itself can cause a blood loss of around 200 to 50. And if during tumor resection, if the bone is involved, if the tumor is involving the dura also and the bone above scalp also, then while removing the bone flap only, there is lot of bleeding. So I would definitely, for elective neurosurgery, definitely would disagree with that guideline that we should have a hemoglobin of at least 9 gram %, should not be agreeing to hemoglobin of around 8 gram %. For seizure prophylaxis, there are certain indications. One of the indication you mentioned was depressed skull fracture, your first case. Along with levetiracetam, eptoin also, the epsolin or the fosphenytoin can also be used. There are certain drugs, first line, second line, and third line drugs. You mentioned about ketamine. Ketamine is indicated for convergence as a third in resistant cases, in the refractory cases of status epilepticus, especially in patients in neurocritical care who are on ventilator. In those patients, ketamine has been indicated for stopping convulsions in status epilepticus. So ketamine is not routinely used as a first-line drug. First-line drug is, of course, diazepam, midazolam, or lorazepam. Then second-line drugs, either you go for fosphenytoin, phenytoin, or maybe levetiracetam. So these are for convulsions. Second thing, I would again disagree with you regarding pupillary reactivity. See, many of those patients we are seeing for the first time and they are sedated and paralyzed in the neurointensive care unit. And a surgeon hurries for that the patient should be taken in an ICU. So at that moment, in a patient who is already sedated and paralyzed and getting the patient on ventilator towards the OT, the pupillary reactivity is there to see in your hand. You should know which pupil is dilated. There is a right side big extradural hematoma or subdural hematoma, right pupil is dilated. Because
So, can I add here something? Usually, hello. Can I add something, madam?
Sure. I don't know whether I'm not able to see anything. My video has gone.
Shilpa,
Am I
yes.
audible?
Ganesh,
Yeah.
please,
Shilpa, I'll finish in 1 or 2 minutes and then we can always discuss. Then second thing is that about damage control orthopedics. Yes, you mentioned about that. We cannot operate immediately all the patients. So we need to practice damage control resuscitation, damage control orthopedics in many head injury patients who have sustained orthopedic surgeries also. So it was a really excellent discussion. All the cases were discussed. Again, some difference of opinion will be there. For the first case you mentioned, GCS was 15/15, but patient had depressed skull fracture. So my opinion would be to wait for some time because these patients may develop hematoma on the second day. Maybe interest just below the depressed level of fracture, there might be some contusion. So wait for 1 day, do a follow-up CT scan after few hours, 12 to 24 hours. and they take the patient. So thank you very much, and we can definitely discuss all the cases needs discussion. Thank you.
Thank you, Dr. Manisha madam. Himangi madam, you want to comment?
You wanted to comment in between regarding her comments?
So I just wanted to say that usually the patients are not paralyzed. They are just sedated and on ventilator preoperatively. Or sometimes they are not on ventilator also. They are just maintaining saturation and they wait for us to be on ventilator, like to put on ventilator when they come to the OT.
Yes, like that. Yeah.
And again, regarding, I think, this
I
hemoglobin level.
was just saying that we should take, it should also be included in our protocol to see people reactivity.
Yes, yes. Yeah, Hemangi madam, yeah, you can.
Excellent presentation. You showed a lot of subjects were covered, and that too showing the latest evidence and the publications and everything you showed very well. A few things I wanted to tell about traumatic brain injury, that the physiology was told very well. Even the traumatic brain, that last in between that slide was there, which showed that there is a difference between the autoregulation of injured brain as well as the normal brain. So after traumatic brain injury, many changes do take place in this. This brain cannot be expected to react in the same way as a normal brain. Not only the autoregulation range comes down, even sometimes the autoregulation might be lost. So hypertension may lead to increase in the hematoma. Hypotension, any amount, may lead to ischemia, acute ischemia in these patients. Similarly, in injured brain, CO2 vasoreactivity also can be lost. Now, whether it will be lost or no, clinically, by assessing the patient, we will not know. So when we are adjusting the ventilation, hypoventilation is definitely not good because there will be increase in ICP. We have to restrict it, as Dr. Katikar said. But hyperventilation sometimes is used to reduce the ICP, can also be dangerous because the normal brain is going to react in the normal way and will have vasoconstriction. But the abnormal or injured brain may not have vasoconstriction. So what will happen? There will be reduced volume of a normal side and no advantage of the abnormal side. So this can cause even worsening of the situation, even increase in the midline shift, and we must keep this in mind. And it should not be, hyperventilation should not be used indiscriminately in these patients. Just the way hyperglycemia is dangerous, it's very easy for us to say that don't give glucose containing fluids. But hypoglycemia is more dangerous. Brain is dependent on glucose. So whenever we are restricting glucose, we must monitor the blood glucose. That is what I wanted to tell. Pupillometry is coming in a big way, but I believe currently we should see the pupils, but so far, because there are too many factors involved, depending solely on that would not be appropriate. And Dr. Manisha also said about difference of opinion in those patients, whether to wait or not wait and all. And there is a valid reason, because not all patients of the same diagnosis are same. Different situations, multiple variabilities are there. And because of that, we have to consider each and every aspect of that and accordingly take a decision whether this thing is needed or no. But everybody must keep it in mind that trauma, head injury is a dynamic situation. And whenever you are in doubt, you must wait and see what is happening. If there is raised ICP, of course, it needs to be dealt with first. But otherwise, if there is no urgency of the surgery, we must wait for head injury to be stabilized. Even the brain reaction to the drugs also may change, resuscitation to become adequate and all, and then go ahead. Again, different situations will be different, whether the head injury is severe, moderate, or mild. That also can be said. Hypovolemia can play havoc into that. Acute blood loss. Acute blood loss, many times patients do not tolerate. So HB of reduced HB, whether to accept it for an urgent emergent patient and then simultaneously give blood or no, that is that can be one of the options. However, the cardiac patients or patients on beta blocker do not tolerate anemia well. So there is a definite proof that if the patient is on metoprolol or propranolol, nowadays hardly anybody takes that, those patients HB, minimum HB should be 9, and without that should not be. So the nowadays current trend is, as far as possible, give this. But if the HB is 8, again, we will see that whether to wait or not wait, or give the transfusion and then take up or not. There are many aspects for every situation and all, but I think we will have to stop here. Very well done, very well explained, and there might be some questions in the chat box. Probably we will deal with that later.
Yes, we'll take the
Yes.
questions later. Thank you, Dr. Manisha and Dr. Hemangi madam, for your excellent comments. I now request Dr. Rashmi Chavan to start with her presentation. Please start sharing, ma'am.
Am I audible?
Yes, yes.
Yes, ma'am.
Slides visible?
Yes.
Yes, ma'am.
Okay. So good evening, everyone. Good evening, Manisha madam and Karnik madam. And I thank SAM's office bearers, Dr. Anita, Dr. Rajesh, and Dr. Shilpa ma'am for providing me this opportunity to present on this web platform. Safe anesthesia saves the life. Okay. So I am really feel privileged. I bring greetings from D.Y. Patil Medical College, Kolhapur. Now my topic is CKD patients for fracture femur, principles of management in private practice. We are directly jumping from brain to the kidney. So in next 30 minutes, I would do my best to give justice to this topic. So why this topic is so important? If you see in the general population, prevalence of the CKD is 11%. In surgical patient, it is 6%. But if you look at the fracture hip, it is 39%. Maybe because of the age, comorbidities, and CKD patient, they have bone mineral disorders, which make their bone weak and muscles weak. Also, these CKD patients are more prone for post-operative complications. It is a 2.5 times more risk of mortality in 1 year. 40% of the time risk of prolonged hospital stay, commonest complications being acute renal failure and myocardial infarction along with septicemia. The commonest causes are type 2 diabetes, hypertension, which are very frequently seen in our population, along with NSAIDs, induced nephropathies and glomerulopathies. So what is CKD? It is an irreversible progressive loss of kidney function. According to the KDIGO, it is either the functional loss or the structural loss. Functional loss in the form of if GFR falls below 60 ml per minute per body surface area, or if there is any evidence of structural damage, or because of the structural or the pathological or histological damage, which is persistent for 3 months or more, then we call it as a CKD patient. Also, the kidney transplanted patients come under this category. So they have graded the CKDs according to the GFR. Grade 5 being the patients, they will not survive unless the kidney transplant done or unless the regular hemodialysis done, where the GFR is reduced to less than 15 ml per minute per body surface area. They are also categorized severity according to the albuminuria. Generally, whenever there is a glomerulonephropathy, there is albuminuria. There is a tubulonephropathy, there is electrolyte imbalance. So whenever we want to know whether kidney function is good or not, what we ask, serum creatinine kitna hai? But serum creatinine is not a specific or a sensitive indicator of a kidney disease. What you have to do is you have to ask for a GFR. The direct calculation of GFR is tedious. We calculate it is estimated according to the Cockcroft formula or CKD EPI, which is more accurate. There are apps also available. You can put figures in that and get the results. You can ask the laboratories also to provide with the GFR values. We know the functions of the kidney. If these functions are deranged, we get fluid overload, hyponatremia, hyperkalemia, metabolic acidosis, renal osteodystrophy, anemia, and platelet asthenia. Because of CKD, there are numerous complications pertaining to each system. So important to anesthesiologist is accelerated hypertension, IHD, then chances of pulmonary edema, autonomic neuropathy, gastroparesis, and patient is susceptible to the aspiration, platelet asthenia, and anemia. So what investigations do you want to have in CKD patients? You should have a CBC because you want to know the degree of anemia and whether you want to keep blood or not. WBC count to rule out infection. These patients are very prone for infection. The platelet count, if you want to go ahead with a regional, it should at least more than 1 lakh. Renal function test, we generally ask for creatinine, BU, and urea. Now here you should ask for estimated GFR values also. Electrolytes, we are in habit of asking for sodium and potassium. In a case of kidney disease, ask for calcium and bicarbs also, because there is invariably there is a hypocalcemia. And generally these CKD patients have mild acidosis, so the bicarb levels are less than 22. But if they are falling below 18, then you should ask for ABG to see the pH also. In coagulation profile, coagulation will be normal, so PTINR will be normal, but the bleeding time will be prolonged. So you have to see for the bleeding time because of the platelet asthenia. The number will be normal, but the quality of the platelet is not good. In ECG, along with the STT and LVH, we have to see for the arrhythmias because of the hyperkalemia. In X-ray, along with the cardiomegaly, we should see for the pericardial effusion or the signs of pulmonary edema. And in echo, rather than having ejection fraction, we have to rule out the pericardial effusion, which is because of uremia. In ABG, in selected cases, as I told you, if the bicarbs will fall below 18. These patients are on multiple medications, so you have to see which they are on which medications and which drugs you want to stop, which drugs you want to continue. Mainly these are the antihypertensives, diuretics, and some erythropoietin and supplementations. If the patient is diabetic, then it is oral hypoglycemic agents. So I will first tell you what are the principles to manage these CKD patients, and then we'll see for cases. So I told you creatinine value is not very sensitive. You go for a estimated GFR. You have to preserve whatever remaining function of the kidney. That is your aim. Okay. Once you suspect the CKD, you have to see for its systemic manifestations. So in cardiac or fluid overload or bleeding tendencies, acidosis, pulmonary edema. There are certain red flags. You should not take these patients without dialysis. Okay. Like metabolic acidosis. Even the patient is on sodamine tablets. If the patient's pH level is less than 7.1, or if there is bleeding tendencies, rather than saying coagulopathy, we should say bleeding tendencies. Hyperkalemia, it is a refractory hyperkalemia going above 6.5. So generally, we don't induce the patient if the potassium levels are more than 5.5. So in between these two ranges, 5.5 and 6.5, you try to optimize it by the like glucose insulin drip or calcium gluconate, or like you treat hyperkalemia with this conservative managed medications like salbutamol nebulization, diuretics, or potassium binders orally. Okay. Fluid overload. Suppose patient shows any evidence of pulmonary edema or CHF despite on being on diuretics and uremic encephalopathy. These are the red flags. You should take these patient. You should not take these patients without dialysis. Okay. The suppose patient is on dialysis or you advise dialysis. Ideal time to take the patients after dialysis is 24 to 42 hours. Okay. So below 6 hours is you should not take. Above 24 hours you should avoid, to avoid hypo or hypervolemia. Volemia. In dialyzed patient also, you should look for the complications of over dialysis, because patient may be having hypovolemia, patient may have reverse things like hypernatremia, hypokalemia. So in this patient, you should have a recent immediate electrolytes before surgery. You should rule out disequilibrium syndrome, and then you should go ahead. During surgery, what you should do, you should avoid nephrotoxic medications like NSAIDs, contrast dye, or aminoglycosides. Fluids, you should not keep patient hypovolemic or hypervolemic. Because of hypovolemia, there is a chances of renal underperfusion, and hypervolemia will lead to pulmonary edema. So my aim should be to keep mean arterial pressure all the times above 65 mm of Hg. and urine output above 0.5 ml per kg per hour all the time. So if I have given the calculated fluids and if there is hypotension, I should give vasopressors early. And in that, norepinephrine is a drug of choice because your methamphetamine and ephedrine, etc., will cause a renal vasoconstriction. As the patient has a hypoalbuminemia, 20% albumin is a colloid of choice. It will maintain the BP also, it will maintain osmotic pressure also, and decrease edema also. If I put a CVP line, every patient should not get CVP line, but whenever I put it, I will keep it as 8 to 10 centimeter. They say fluid of the choice should be NS, RL should not be given, it contains potassium, but it is not. Whatever it is, I told you, in a dialyzed patient, it may be the reverse way. So according to the electrolytes, I will decide which fluid I have to give. Trigger for blood transfusion is 7 gram because these patients are chronically anemic and because of compensatory mechanisms, they are well tolerated. And blood transfusion will call alloimmunization, which may cause in future graft rejection of the kidney transplant. Whenever you want to give a blood to these patients, you have to ask for leukodepleted or irradiated blood, and which is a CME negative. Okay, so you have to make the arrangement if you want to give a patient blood to the patient of a CKD. So you have to contact to the blood bank and ask for such type of blood. In suppose patient has CKD and is also cardiac, then my transfusion trigger will be 8 gram%. It is better to have a HbA of 10 pre-operative with erythropoietin and not with the blood. These patients have platelet dysfunction, so platelet count will be normal, but bleeding time will be prolonged. And suppose I think, and there is evidence of some bleeding like epistaxis or this thing. Desmoprocin is an injection which can be given subcutaneously or intravenously preoperatively. The onset will be in 1 hour and duration will be 4 to 6 hours. Only if there is a evidence. And suppose during procedure, if there is a bleeding, the choice of this is a cryoprecipitate and not the platelets. Because giving platelets will not help, you have to give cryoprecipitate, which contains whole villebrum factors and factor 8 along with fibrinogen. So monitoring standard will be routine. Only thing that you have to have urine meter and hourly urine monitor, hourly urine output. Central line only in selected cases, which are not candidate for dialysis, but shows the sign of some certain fluid overload. So I am worried about intraoperative fluid management. In that cases, I will put central line. And if I suspect that these patient might require vasoactive agents, then I will put central line. Arterial line, it is only cases for the cardiac. So renal is not the indication for arterial line. So suppose patient has a diastolic dysfunction more than grade 2, patient has a low ejection fraction, you are suspecting more fluctuations in the blood pressure, or patient has an intractable or refractory hypertension which is not manageable even on a 5-6 drugs, then I would like to have an arterial line for having a proper control over it. It is advisable to take it from the lower limb. All the things which are saying is to save the arteries in the future AV fistula, save the this thing for the future surgeries. Okay, so we'll take some cases. So first case, 66 years, male patient, 62 kgs, history of fall, known case of hypertension on telmisartan, and you have seen this patient for the fracture, PSC. And in PSC, the meds are okay, grade 2 dyspnea, no signs of fluid. Patient doesn't give any history of renal disease. But when you look at the labs, HB is little bit low, 9.2, and creatinine is 3.2. Okay, rest of the parameters are within okay range. So to my mind, it comes whether it is a chronic kidney disease, whether it is acute kidney disease. So, but as the patient is on hypertension on telmisartan, the possibility of hypertensive nephropathy may not be ruled out. So I will take a nephro opinion. I will explain the risk of acute kidney injury and dialysis in post-operative period. But as there are no red flags and urine output is adequate, I will go ahead. So I will go ahead with my standard assay monitors, and goal will be the same: preserve kidney function by avoiding nephrotoxic dose, maintaining MAP, and maintaining urine output. So how I will do it? So my plan for this fracture hip patient will be regional anesthesia, which is spinal anesthesia with epidural along with the blocks. Okay, I'll tell you why. So I will keep this patient minimally fasted. So 6 hours for solid, but I will allow or encourage the clear fluids till 2 hours because I don't want to calculate that deficit for NBM hours. So I would just like to give him the maintenance fluid and whatever it is a loss intraoperatively. Preoperatively, I would like to give a sci-fi block. So we have USG machine, so we give suprainguinal fascia iliaca block, which is very superior. I will start him with now which fluid. So his electrolytes were normal. Anything will okay. So I will start with a Ringer's lactate. I will follow with 500 cc's during the procedure till I am giving the block, till I am giving the epidural. Epidural will be put on the L2-3 space or whatever it is, just one space above the spinal level. And spinal will be given with a low dose, which is a 1.5 cc of bupivacaine heavy with 25 mics of fentanyl. So by giving low dose, there should not be any hemodynamic perturbations which requires fast fluid administrations or vasopressors. And suppose procedure extends and suppose there is a level is not adequate, I can supplement with the epidural anesthesia. Intraoperatively, I can give midazolam and fentanyl in the small doses if required. Okay, so in fluid management, maintenance fluid will be 200 ml per hour, and blood loss will be replaced with the equal volume of crystalline and not the 3 times the crystalline. So hypotension, if hypotension happens with lower spinal level, hypotension doesn't happen. But suppose if happens, I will treat it with a 200 cc of bolus of Ringer's lactate. And if it is not maintained with that, I will immediately start norepinephrine drip in 2 to mics per minute. My aim will be maintain the urine output 0.5 ml per kg per hour and MAP above 65. So it is just calculations. So 2 hours surgery with 500 ml of blood loss. So my estimated blood loss with a trigger of 6 is allowable is around 1 liter. So it is inside of that. So 500 cc will be replaced by 500 cc crystalloids. So total 500 to maintenance of 2 hours is 400 and whatever I co-load with 500. So total 1400. So I will give either 2 RL and 1 NS. So whenever I am using normal saline in this patient, I should see to it that I should not exceed 1 liter of NS to avoid hyperchloremic metabolic acidosis. Post-operative same, I will give tramadol is safe. The little prolonged duration of action will be seen, but as this patient is in mild to moderate variety, I will not be worried about. Paracetamol is safe. For DVT prophylaxis, I will reduce the dose from 40 to 30 milligrams of enoxaparin. Okay. If I want to keep the catheter for a third day, suppose I want to give some analgesics through catheter, so I will remove the catheter according to the ASRA guidelines after the 12 hours of last dose. Coming to the second dose, now this is a known case of CKD with fracture femur, and patient knows he has some kidney issues. Patient is diabetic, patient is hypertensive, patient on all battery of medications, you see multiple antihypertensives. But when you examine, patient is pale. Patient has little bit pitting edema, mild facial edema. Patient doesn't say he is dyspneic, but you are seeing respiratory rate is 22. Room air saturation is 94. Few crackles at the bases. Okay. These are the patients which are little bit of tricky type. Okay. So when you look at the investigation, HB is 7, WBC, PTIN are okay, but creatinine is 5.2, potassium is 5.3, sodium is 130, calcium 8. Rest of the things are good, but I would like to have estimated GFR in this patient because I am seeing patient is not well compensated on the oral medication. So whenever I ask for estimated GFR, it is 11, which is too low. Okay. I will ask for ABG, I will ask for serum protein, X-ray chest, bleeding time. So see the parameters. So bicarb levels 15, pH 7.1, and proteins albumin little low. X-ray shows higher structures, means it's signs of like congestion. Okay. So that means these are totally red flag. I should not go ahead without dialysis. So I will take nephro opinion and send patient for dialysis first. Though these people are very, this thing, fracture femur, you have to fix it in 12 hours, you have to fix it in 48 hours. I will take my time to optimize these patients. These are the patients not to be hurried. So case to be done at a setup where the facility for dialysis, proper monitoring with quick laboratory reports are available. And when I advise the dialysis, generally they do heparin-free dialysis because it is a fresh fracture. And but whenever there is a first dialysis, after titration, they come to know how is a dry weight. So for first time, there are very chances that a disequilibrium syndrome. Disequilibrium syndrome is nothing but a brain edema, because urea from the brain will not be diffused as in plasma. So patient will have a cerebral edema like picture. So these you have to diagnose it, because mortality is very high in this patient. You have to rule out hypovolemia, hypotension, hypernatremia. Surgery should be within 12 to 24 hours of dialysis. I would like to have all fresh electrolytes, CBC, morning sugars, creatinine. So as pehle se HB was 7, now after dialysis it is going to fall. So I would like to keep 2 points ready. So how blood should be? It is irradiated. Again, sometimes they say when you are doing dialysis, you already know patient is anemic. Do blood at the time of dialysis. It will save your post-operative problem of hyperkalemia. And so on the day of the surgery, as there is, of course, morning doses of antihypertensive, intraoperative patient is on OHA, I will give intraoperative insulin. That is there. But as there is no coagulopathy, evidence of coagulopathy, I still go ahead with a regional anesthesia with block. My plan will be same. Give small dose of spinal, supplemented by epidural, and sci-fi block for post-operative also analgesia. Also, it will help the patient, make them sit for the neuroaxial procedures. If there is a dialysis catheter, I will use it for CVP monitoring. I will not give fluid through it, okay? I will use restricted fluid therapy, as I told you. Now it is patient is very tricky. So my now choice of fluid, okay? So after the dialysis, if you see the electrolytes, potassium 3.2, sodium 140, okay? So it is already on the lower side. So my choice will be Ringer's lactate. Hypotension if intraoperative. So previously I have given the co-loading with 500. Here I will just give 250. Again, I will keep the patient only 2 hours in the 2 hours for clear fluids. So I don't have to infuse with a deficit volume. So only the maintenance and the whatever is the intraoperative loss. So co-loading with a 250 ml of Ringer's lactate. And if hypertension occurs, same thing. Only now the bolus doses are little low. 150 to 200 milligrams of bolus crystalloid. And suppose if it is not maintaining, I will start with epinephrine, norepinephrine drip. And suppose this patient, we have done the protein levels. This is having hypoalbuminemia also. So intraoperatively, 20% albumin I can give, which will maintain the intravascular volume also. And blood, because as blood transfusion trigger is 7, I would like to have irradiated blood in the OT itself. Okay. So arterial line, again, it is not required because my patient is not of the indicated for the cardiac. So what will be his fluid? Suppose 1.5 hour surgery is done. So 50 ml per hour is only maintenance in these tricky cases, and urine output of the last year you should, and plus blood loss S. So suppose if this patient is of 1.5 hour surgery and 400 of total blood loss. So 250 ml of co-loading, 1.5 hours into 50 ml per hours of maintenance dose, 200 ml if the patient has hypotension, whatever I have infused, plus blood, that comes around 900. Of that, one blood I will give, and 600 ml of Ringer's lactate I will give, along with a 20% of albumin. Post-operative, I have to monitor this for the electrolytes, strict hourly urine output, because these are the patients which are likely to decompensate fast. And I will not keep them very much fasted. So early oral intake and whatever it is, a fluid given post-operatively, same 1 ml per kg per hour. In DVT prophylaxis, I would not like to have a low molecular weight heparin. I will give unfractionated heparin, because suppose I have to reverse the effect, it is easy for with protamine sulfate. So suppose there is a problem with regional anesthesia, I cannot do the spinal, or if there is a patient's refusal and you are not very this thing. So I can go ahead with a general anesthesia with some precautions. Okay. So I have to take consent for the post-op ventilation also, because I don't know how these patients will be post-operatively doing. Then I will give anti-aspiration prophylaxis, avoiding proton pump inhibitors, and pre-medication. Midazolam has a 5-hydroxy metabolite which is active. Fentanyl has no active metabolite, but 7% it is excreted unchanged. So the doses, all the distinct doses now will be prolonged effects. So I will give little reduced doses. Also, the CKD patient, they don't require much doses. So with the little reduced doses, I will pre-medicate them. Propofol is safer for this patient, but give slow as we don't want a precipitous fall. So we'll give 1 milligram per kg, and then we'll slowly, if the patient is under this, I will just stop there itself. Okay. As the patient is at the risk of aspiration, so I will use the rapid sequence induction with propofol only. And succinylcholine can be used if the potassium is less than 5. As my patient is, suppose potassium is more than 5.5, rocuronium will be my the drug of choice. But less than 5, I am okay with succinylcholine. Ismolol and Zalocard will be used for the pressure response because these patients are already hypertensive. So in rocuronium, they say you have a Sugamadex to reverse it. But in chronic kidney disease is a contraindication for the Sugamadex. If you find any literature which says in chronic kidney disease it can be given, you can use it. But as far as it is contraindicated in chronic kidney disease whenever it is a GFR less than 30. Atracurium, cis atracurium are safe. Given a choice, I will use this atracurium because laudonosin is less and there is no less chances of accumulation and neurotoxicity. CO isodesfluran and said they say with CO there is a compound A, but it is in animals or fluorides which are nephrotoxic, but it is not at the in human studies and you can safely use. Nowadays dexmedetomidine is safe, you can use it. And whenever I am giving GA, rather than having hypotension, the problem may be the hypertension. So dexmedetomidine will take care of that. Intraoperative, the fluid management will be the same, keeping MAC of 65, above 65 and urine output more than 0.5. Post-operative analgesia is also same, tramadol and paracetamol. Paracetamol can be given even 6 hourly also, and tramadol with little bit of more spacing. If I am giving routinely, it is 12 hourly, I will give 16 hourly. Even if it is a GA, it is always with a blocks. So GA with a sci-fi block. If you don't have a USG, you can go for fascia iliaca compartment block, which is a landmark guided. You can go for a PNS guided femoral block, but always give with a blocks. Is there any role of diuretics? Not as a routine to bring out urine output. Suppose there is no urine output, you cannot just give diuretic and see for the. Only if there are signs of overload or edema or pulmonary congestion. Suppose patient is under GA, there will be signs of raised airway pressures and some crackles, decrease in saturation, and the patient is already having edema, etc. Then you can give. Otherwise, there is no role just to give diuretics. If CVP you are measuring, then you see CVP should be more than 10. So whatever, suppose you are doing all whatever I said, give this, give that, but urine output is less than 0.5. What you have to give? Give 200 ml of fluid bolus. See the response. If it is responsive, continue with 1 ml per kg per hour. Measure the CVP. If it is less than 8, again give one more bolus of 200. And if it is not improving with this thing, give norepinephrine infusion and keep the MAP more than 65. Diuretics are strictly only if the signs of overload. Suppose case 3, well compensated CKD. Patient is roaming around, patient is having no signs of overload, no signs of acidosis, no signs of bleeding. But if you look at a creatinine, it is a 9. What I should do? Okay, patient says, I am climbing stairs, I am doing everything. But you know his GFR will not be the same. So I will require all battery of investigations, including ABG, including echo, to rule out any indication for a dialysis. GFR less than 15 itself is a indication for a dialysis. Counsel the patients and relatives. He may go in acute renal failure anytime. Intraoperatively, I will put central line. I will do meticulous fluid management along with the vasopressor. And again, no coagulopathy. I will go with a regional anesthesia. Case 4. Well compensated on dialysis. Patient is already on dialysis, regularly doing 2 times a week, 3 times a week. I should not be worried much because everything will be taken care by the dialysis. My fluid problem, my electrolyte problem, my coagulopathy, uremia. So these are patients are better than which are on the verge of it. Also, they are not dependent on the kidney anymore. I should not be worried about kidney more injury to the kidney. But I will require all investigations. I will see how the dialysis is optimizing, how is his dry weight, what are the fresh electrolytes, there is no over dialysis or that CBC on that morning. And if patient has AV fistula, I have to take care of that. No line on that IV line on that arm. BP cuff should not be on that arm. Properly check for the patency, wrap with a bandage and Gamgee, label it. and take care during positioning also. They give lateral position, they give different positions. So I have to take care of that hand during positioning. Case 5, transplant patients coming for the surgery. I told you, transplant patients are also CKD patients because only one kidney is transplanted and it has also has a lifespan. After certain years, the kidney function will decrease. So patient transplanted coming to me after 6 hours, its kidney function is decreased more than 50-60%. But the principle remains the same. I would like to have all battery of investigations, and I will continue whatever is the immunosuppressant he has. Additionally, I will give steroid dose intraoperatively. Broad spectrum antibiotics to be used, and see to it that what are the side effects of immunosuppression. Sometimes this cyclosporin or will cause a hypokalemia. There is increased duration of muscle relaxant. So generally they used to say in transplant patient, send these transplant patient where they have transplanted. So but nowadays we are seeing them frequently. So we should be knowing what we should do in these transplant patients. So generally, you see, if it is a well controlled patients, you can still take care. Of course, any patient with CKD, you have to take consent for the requirement or counsel for the requirement of any time dialysis post-operative period also. So transplanted patient or CKD patient on. So these are the tricky case for patient. CKD on conservative, but some signs of fluid overload, edema, this should not be taken at lightly. This should be taken at these patients should be done at a higher center where facility for a dialysis and labs and proper monitoring is there. So what is my take home message? Whenever we come across the kidney disease, we have to stratify it, see at what level it is and what is its effect on the other system. Optimize first, okay? Electrolytes, fluid, coagulopathy. Optimization comes first and then comes the surgery. Identify the need of dialysis pre-operatively. Intraoperatively, maintain MAP, avoid nephrotoxic drugs, and you see to it that urine output is more than 0.5 ml per kg per hour. Assess the need for dialysis post-operatively also. So patient requiring dialysis or with symptoms and signs of uremia or overload, better to do these patients at a higher center where perioperative monitoring will be done, SOS dialysis will be done, quick lab reports are available. Principles to manage CKD patient perioperatively remain same for teaching institute, private practice, corporate setup, even if it is for a fracture femur or for a obstructed hernia. So thank you very much. And now this topic is open for discussion.
Thank you, Dr. Ashmi, for a wonderful presentation, very crisp and covering almost everything in CKD. It's also a very vast topic. Please
Thank you,
stop
madam.
sharing. And I now request Dr. Katikar madam and Dr. Karnik madam for their comments. And then we'll go for the questions.
Excellent presentation. Again, so many things were explained. In fact, whatever I had in mind, it was practically all points were answered. Literally, as you said, that there is no linear relationship between the renal functions and the kidney dysfunction. Even if the slightest dysfunction is there, a significant kidney tissue loss is there. So everybody should keep that in mind. And creatinine thoda hi jyada bada hai should not be taken the things lightly. It is a significant renal volume loss. So that needs to be taken. Just I wanted to say that many of these patients would have some sort of acute renal dysfunction also when they come for the surgery. So we should try to identify. Just because the patient is known CKD doesn't mean that there cannot be acute element overriding on that. And as Madam said, that we need to identify that, make sure that it is explained to the patient. It does not create additional issues in the perioperative period and prevent that. But at the same time, preoperatively also, we should try and identify. Quite often the fracture patient goes from one place to another patient every day, is starving, and the dehydration adds to that element. So we need to hydrate the patient and check the volumes and all. I agree with Madam that during the preoperative dialysis, it is the best time to give the blood transfusion, because then the patient will not have the volume overload effect. So that can be easily done when the patient needs preoperative blood transfusion, especially very low HB and other things. Whenever patient comes for surgery after a dialysis, an anesthesiology must know certain aspects about the dialysis. When was it done? How was it done? What was the type? Whether heparin was used or no? Whether blood transfusion was given or no? What was the weight or before before dialysis and after dialysis? Hemoglobin pre and post, electrolytes and coagulation, hemoglobin. All those things we need to check before and after. So with that, we come to know the efficacy of the dialysis, and that would be good. Your cases were excellent. All 5 different types of cases you have explained and all. And renal transplant patient, when that patient comes, the few things we have to remember and do it. In fact, for today's CME, I remember one of my case which fits into both the lectures today. One patient had come with the head injury, and we operated in emergency. Patient came unconscious and operated. 1 day of ventilatory support, next day extubated. And next day when I was taking round, he told me, he was an elderly fellow, apparently okay. And he told me that, madam, I have been transplanted so many years ago. And none of us knew it. So since admission, he didn't receive any drugs or so. So immediately we mobilized, we went to the nephrologist and mobilized 1 dose of immunosuppressants that we could catch hold of. And he was an ex-army man, and immediately next day he was shifted to his own higher centers and all, and everything went off okay. But the fact remains that if it is a post-transplant, we need to know that such patient has certain priorities, and that needs to be tackled. Otherwise, without unknowingly, we may do harm to these patients.
Thank
Very
you.
well explained. Yeah.
Very
was
good. All
really-
cases were really very good, and you covered the whole spectrum of CKD, right from the just slightly increased creatinine to a complete fully developed CKD and a transplanted patient. Very well, very well.
Thank you, madam.
Yeah, with Dr. Rashmi's excellent presentation, including all those 4 clinical cases, and then Himangi madam's description, I don't think I have to add anything more, because the cases has been means I really liked the way she explained about the calculated fluid balance, because these patients we need to give the fluids very carefully, CKD patients. So that calculation of fluid requirement which Dr. Rashmi had mentioned was excellent. Second thing, I think she must have mentioned, but I thought that before planning for regional anesthesia, it is important to check for the platelet count and the coagulation profile that you had already mentioned. But it is very important when we plan any anesthesia, any regional anesthesia in such patients, we have to know about the platelet count, because again, CKD itself is known to cause thrombocytopenia, platelet platelet dysfunction, thrombocythemia, and so many things. So that should be the important message for the PG students, that they must know the platelet count, they must see the blood coagulation profile. Secondly, you said about succinylcholine, it should be avoided because there is a risk of hyperkalemia and it can be very hazardous and very dangerous. Even if you don't want to use rocuronum suganimate complex, you can always intubate the patient. Rapid sequence induction can be done with longer acting muscle relaxants, so like a vacuronium or a tracurium. There are multiple studies that have been already published in, there is a clinical research for use of sugammadex in patients of renal failure, and they have mentioned, I don't remember exactly, but I think it is, if the GFR is more than the calculated, the estimated GFR, or if it is more than 30 ml per minute, I will have to clarify and to see again. Then sugammadex can be used in these patients. Maybe in patients with severe CKD, it is risky, but the component, that is the sugammadex as well as the rocurinum component that that is formed in the plasma is a very stable component and that gets excreted and changed in urine, or even if the patient undergoes dialysis, it can be removed by dialysis. So Sugamadex can be safely used in patients with maybe mild or moderate kind of renal failure or CKD. So that should be another addition to what you are saying. Then again, something to mention about cis-atracurium. Atracurium is very safe because it is metabolized by Hoffman degradation and ester hydrolysis. But cis-atracurium, they have mentioned that, the textbooks have mentioned that the clearance is around 13% or 14% of clearance is hampered in patients with CKD. So they may have delayed action. So that has to be taken into consideration when we are so the textbooks have mentioned that the safest drug is atracurium. Another thing you mentioned about is disequilibrium syndrome. Yes, these patients, they behave like patients of encephalopathy, and it is very critical situation. Patient may get convulsions. Patient has raised ICP, so that has to be kept in your mind when you are managing CKD patients. But overall, it was an wonderful presentation, and of course, when it is a fracture femur, we would definitely, all of us would love to go for regional anesthesia, checking the platelet count. Thank you.
Two things I would like to mention more is nowadays most of us have the access to USG, and we must learn that these patients have very high chances of pericardial effusion. So we must have that habit of looking at it, especially when the patient comes with the edema and all. And it will be very easy to master, but just keeping our eyes open towards the possibility of pericardial effusion. In CRF patients, especially those who are dependent on dialysis and all, would be useful in treating it, because if the patient goes into hypotension, we will know that how to treat it. And if required, even very rarely nowadays we get that bad kind of CRF, but we have done the pericardiocentesis ourselves and all. So if you have that thing in mind, it can be easily tackled. Another thing is CRF patients do have brittle bones, and the cribriform plate is also very brittle. So while inserting the RT, you need to keep that in mind, and either you can avoid it or at least make sure that you don't damage it. Otherwise, that RT in the brain is the situation that can happen in this kind of patients. So we have seen those complications, and
in fact, fractures are more common. Fractures are more common in CKD patients because of hampered calcium metabolism or renal osteodystrophy. So any fractures are known in patients.
Overall,
they are more, the incidence is more and more in.
Overall, they have frail and poor health.
Yes.
So, let us take some questions. One question for Shilpa. What hemodynamic management in a case of intracranial hypertensive bleed, which is posted for decompression surgery?
Yeah, so hemodynamically, we try to maintain the mean arterial pressure at least 90. If not 90, then between 80. Am I audible?
Yes.
Yes. Between 80 to 90 systolic mean pressures, and correct the hemoglobin if there is blood loss. And as everyone said, for this traumatic brain injury, we take HbS 9 gram%.
Yes, actually, you have answered during your presentation to this question. Yes. Dr. Naresh Paliwal has commented.
Anita madam, I just want to add something here.
Yes.
See, these patients who are hypertensive intracerebral bleed, they have a very labile hypotension, especially labile blood pressure, especially that you have to be very careful when you're inducing such kind of patients with propofol. You have to give the propofol meticulously because there is a significant hypotension after induction. So the preoperative BP may be 210 by 110, but after induction, you may see that if you give rapid dose of propofol, looking at the blood pressure, higher dose of propofol, then you may get a BP of maybe 80, 90 systolic. So you have to give titrated doses, and that has to be very, very given meticulously, especially in patients who have hypertensive intracerebral bleed.
Yes. So moving forward, There is a comment by Dr. Paliwal that there are so many options for fracture neck femur. A spinal with hyperbaric, isobaric, or hypobaric combination of any two, or combined with epidural or continuous spinal. Dr. Paliwal, as we all know, is a proponent of isobaric and segmental spinal. So he has commented about that. Now there is another question, another comment. Arterial line is a must as all CKD patients invariably have cardiac issues and all kidney recipient undergo angio before transplant. Okay. So Dr. Rashmi has mentioned that if it is a severe CKD, then you need to do art line and you need to do investigate for the cardiac problems. Are there any more questions? Dr. Vaishali has raised her hand. You can unmute and Ganesh, please.
Yeah,
Yeah. Yes, Vaishali.
thank you. Thank you. Excellent presentation by Shilpa and Dr. Rashmi. Dr. Rashmi, I just want to add few things. Art line is must because the cases you presented are very difficult. First one was okay. From second one onwards, they were all sick patients. So it is always better to, if you need ABG in the pre-op period, it is always better, especially patients with fracture neck femur, they are all old patients, put art line. Because you don't know anything can happen. So always put art line.
Okay.
So that you can check their glucose, their acidosis, everything during intraoperative phase. Then second, if your platelets are low, please give platelets, not cryo. Or do TEG, but I don't know how many
No,
people
no.
have
Now, if the platelet count is okay, and if the platelet coagulopathy is because of the platelet asthenia, decrease aggregation, that time they say by giving platelet, already patient has uremia, so that uremic granules will go and stick onto the new platelets also, and it will not help because already your count is good. So that time you have to give cryoprecipitate. It contains 1 milligram factors, and it will add to that stickiness to the platelet. Even erythropoietin can be given because by increasing the blood volume, it pushes the platelets to the periphery, and so it will do the job. Likewise, means whatever I have read. So I have not come across the
no.
platelet.
You wrote there
हाँ.
if platelets are low, give cryo.
No, no,
So
no.
better
That, हाँ,
do
हाँ,
TEG.
हाँ. Do take that. That is right. What I want to say, if the count is normal and if still patient has coagulopathy and you are thinking it is because of platelet asthenia, that time, if the platelets are low, yes, you are right, ma'am. Okay.
And
Dr.
then
Vaishali, you want to put art line just for sampling or for the blood pressure monitoring?
better for blood pressure monitoring on the other hand of AV fistula. Because there are sick patients, they change the position, they'll bleed suddenly. I have seen a patient who had fat embolism and she died on the table. It was so bad.
Yes.
So it
The
is
NIBP
like
readings are really not reliable in this.
no,
They
not
keep
reliable.
fluctuating so fast.
And for when you give albumin, instead of giving 20%, give 4.5% because 20% will remain for long time in the body, and we don't want that for these patients.
Okay.
But do we have 4.5%? I thought we have.
Yeah, it's available.
4.5%.
4.5% is 500 mils of bottle, and even 5% is
5%.
500 mils of bottle.
5% we used to use.
Yeah.
Dr. Vishwanath.
And then last one is give packs red cells instead of giving whole blood to correct hemoglobin.
Yes, sir,
anemia.
that's true.
Yes. Nowadays it is only pack cells.
Yeah.
Irradiated.
Yeah. That's it. Thank you.
Thank you, madam.
Dr. Vishwanath, please unmute yourself and ask your question. Ganesh, please unmute Dr. Vishwanath. Are there any more questions in the chat?
Hello.
Yes. Sir, audible.
Excellent presentation, madam.
I am a urologist and we see many patients with CKD. We need PCN and RIRS, and there is a very high risk of sepsis, which I think as an anesthetist also you have to take care during or intraoperatively.
So extra shot of antibiotic. What means apart from aseptic precautions? What we should do? Hello, sir.
No, routine, whatever, but only this point I have to.
Okay. Yes. They are because the cell mediated immunity and that is all hampered, so there are very high chances of sepsis. Yes, sir.
Usually they give tazocine. If they are giving 3 times a day, they give 2 times a day. It's like that.
Reverse.
Another thing what madam had mentioned, Himangi madam, regarding immunosuppressants, many of these patients who have received transplant, they're also on steroids. So drug history is very important, I feel, in a patient. If he doesn't give any history
Yes.
of...
No, I mentioned that extra shot of steroid intraoperatively should be given in these patients.
And that history has to be sought
Has to be,
carefully from
yes,
the
yes.
patient,
Correct,
because we
correct.
need to give perioperative steroids in this patient.
Correct.
Yes, so all questions are answered by the speakers in their wonderful presentations, extensive presentations. So they have covered everything. So there are no more questions in the chat, only comments, and we have already covered them.
Really very well explained. Both
Very
the
well.
lectures were
Yeah.
very nicely.
And they had included clinical cases, so
Yes,
that made the
that was
discussion
a
more
very good
interesting.
part, that the clinical cases were included just after the theory part, after the lecture. So, you know, how to differentiate between this case and this case. Immediately it was, you had given the answer. That was very good. Both the speakers, even Shilpa and Dr. Rashmi. Yes. So if there are no further questions, Rajesh, shall we wind up?
Yes. Today's webinar was excellent and it was very practically oriented by our own speakers from Maharashtra only, Dr. Shilpa madam and Dr. Rashmi Chavan madam. To start with, I'm very thankful to Dr. Manisha Katikar madam, GC National ISA, who is always there to help us in every aspect and crisis to the SAM. Thank you so much ma'am. Thank you, Dr. Himangi Karnik madam, for sharing her valuable time and expert opinion on both the topics. Thank you very much. Dr. Shilpa madam, thank you for excellent talk and on managing traumatic brain injury for the various cases, and Dr. Rashmi Chavan ma'am on talk on fracture femur fixation in a patient of CKD was truly enlightening. We appreciate the time and effort taken by both the speakers to provide clarity and the anesthesia management principle. Thank you, both the speakers. Thank you to organizing team, Dr. Anika ma'am, President SAMS, Dr. Saurabh Brateshwar, Vice President of SAMS, and Dr. Parnat Jaban, the SAMS newsletter editor. And thank you so much to our esteemed SAMS members who have attended this webinar and which makes it household. Thank you so much. Thank you.
Thank you, Dr. Rajesh sir and Dr. Anita madam for the opportunity. And thank you, chairpersons, for the wonderful insights. And I actually salute you. The neuro topic, the more you read, you feel you need more. It is so interesting. And you both are doing it day in, day out. Really salute to you. The physiology.
In fact, your slides was for revision, because cerebral physiology you need to revise very frequently, and they were so nice slides and it revised our physiology.
So much in detail I was reading about neuro, and oh God, like at one point noradrenaline is released, at one point it causes constriction, at one point at beta receptors, at other point it will cause dilatation. So I was wondering like how the brain physiology changes every moment, every age.
And it is so heartening to see that when we read it again and again, even our understanding of the physiology improves. With every
Yes,
read,
yes.
we know more things than before. So our understanding improves again and again, keeps
Yeah.
improving.
I just want to ask Himangi madam, your opinion about hemoglobin of 8 gram% for a brain tumor surgery, because I mentioned many times the bone is involved, and when they are doing the craniotomy, there is if suppose it is a meningioma, and if dura is in the bone is involved, dura is involved, there is when they are removing the bone itself, there is lots of bleeding.
For all practical purposes, we
guidelines
also
are
use
there.
9.
Yeah, the guidelines are there, but for elective tumor surgery, hemoglobin of 8, I think doubtful. Yeah, it is a guideline.
No.
That's what we can say.
Isolated hemoglobin, rather than considering whether to transfuse based on isolated hemoglobin reading, will not be appropriate. I would also consider how fast the patient is bleeding, whether it is controllable or uncontrollable, what is the hemodynamic status of the patient, whether the volume status is adequate and otherwise stable or no, and what are the comorbidities, whether patient will be able to tolerate or no. Otherwise, quite often, even 7, 8 is quite okay if the patient is controllably bleeding and we keep the low circulating hemoglobin, like how we keep it for acute normovolemic hemodilution, that sort of behavior we can do. However, quite often in basal meningiomas, the bleeding can be uncontrollable. And then we don't know, the liters have lost and the blood is not coming on time. And that situation, even with the 8 gram, I would ask for the blood. By the time it will come, further more loss would take place and all. So I would see the whole situation and accordingly decide. If the convexity meningioma, even if the HbA is 8 and almost most of the tumor is out, probably we can withhold, and after some time automatically it might be okay. So it depends on the whole situation rather than the HbA.
Yeah, even a frontal glioma, there is hardly any blood loss. A malignant tumor like a frontal glioma, there is not much blood loss. So as you said, we have to see the pathology, the CT scan and everything
And
before
what
taking
more
a
is
decision
going to
about
happen in the next 15 minutes, 20 minutes.
Yeah.
Okay, nice meeting.
Yeah, nice meeting you all. Let's meet
Thank
in
you all.
Mumbai now. Let's meet in Mumbai.
Yes, on 20th of April.
Surely we'll
Yes.
meet, yeah.
Yes,
Before that,
yes,
there
yes.
is Pune meeting.
Pune, okay.
Yeah, thank you all.
Okay, thank you all
Thank
and
you.
good night.
Good night.
Yeah, good night. Good night.
मॅडम मीटिंग एंड करायची का?
हो हो